Doctors, on behalf of Microlabs, I welcome all the doctors who have joined us from across the country to this Pride program. And today we have some of the eminent panel members here to discuss with us on some of the interesting aspects of diabetes management. So first, let me introduce Dr. Ashok Kumar Das, who is going to moderate the program with us. We thank you very much, first of all, sir, for agreeing to moderate the program for us. And we also have Dr. Shubhankar Chaudhary from City of Kolkata. We welcome you, sir. We are honored to have you today with us. And we also have Dr. Shashank Joshi from the City of Mumbai. Welcome, sir. Thank you very much for joining us. And we also have Dr. Jeevan Joseph from God's own country from the City of Kottayam. Welcome, sir. Thank you very much for joining us.
The combination therapy is the most important contemporary challenge to treat type 2 diabetes in our country. Why I say so? It will be evident when you listen to the introductory remarks which I will ask Shashank to give. Shashank, what is the state of our nation as far as diabetes control is concerned?
So, Professor Das, I thank you for this opportunity. At the onset, I want to thank Microlabs and this Pride initiative, particularly Sheshgiri and his team. And it's a pleasure and delight to see Shubhankar Dada and my good friend Jeevan. We are 8 billion people on planet Earth. 1.46 billion people live in India. And worldwide, around 500 million people are living with diabetes. Another 500 million plus people are living with pre-diabetes. And if you see the ICMR in-depth study, which you are an author and Dada is author and I'm an author, currently 101 million people are living with diabetes and around 236 million people are living with pre-diabetes. So if you see worldwide, 1 in 8 people are living with diabetes or pre-diabetes. And the control is the key. Now, control has 3 components, if you ask me. But today our focus is glucose control. So, you need A, B, C, D, E, F for diabetes. A for A1C, B for blood pressure, C for LDL cholesterol, D for diet, E for exercise, F for feed. But the A1C control, if you're looking at non-pregnant adults below 7%, more than 90% of people living with diabetes are not achieving that target. Okay, and this is a worldwide phenomenon. So India is no exception. So a mean average A1C from different studies and data sets, on an average is between 8.5 and 9. And in the first decade of a diabetic's life, particularly our focus of discussion today, I presume is type 2 diabetes, because type 1 diabetes or gestational diabetes or secondary diabetes, the treatment is replacement of insulin. But type 2 diabetes, which is 97%, 99% of the garden variety diabetes, which we see, is heterogeneous, has a lot of clusters, but the A1C is between 8.5 and 9. That's the status of control. And in the first decade, we need to hit hard, hit early. And therefore, the control of diabetes, even in the best of centers, remains poor. And that's linked to compliance, that links to lack of adherence, that's linked to multitude of factors, including continuity of care. So the multiple C's which are involved in control include continuity of care, compliance, cost, and of course, convenience. And all these lead to a poor control. And this poor control directly is translated into outcomes. And the next C comes up, which is complications. See, we should have a goal of having a diabetes-free world and a diabetes-free India. But that is a utopian goal. Our current goal should be having a complication-free world of people living with diabetes. And in that goal, our control is very poor. And I would say a ballpark figure of 8.5 of an A1C average is seen in garden variety type 2 diabetes, because it's impossible for 1,000 endocrinologists in the country or 5,000 diabetes experts in the country to treat everybody. So the mass majority of people living with diabetes are actually going to primary care. And therefore, it's very important to understand one concept: hit hard, hit early. And for a majority of the cases, we are aiming at an A1C below 7%. Of course, we would love to keep it at 6.5. And, there are relaxations up to 7.5. But between 6.5 to 7.5, a mass majority of 80% of people are not in control. So 4 out of 5 people living with diabetes in India are not in control. That would be the state of our nation. So this is a poor state of control.
I think Sasank, in your own inimitable style, you have given the message, which is loud and clear. We have large number of diabetes. The problem is how do we control them? Because the control is too bad, which resulted in lot of metabolic complications, which came out in the paper you referred to, that we all published together along with Mohan and Anjana. That is the paper that said that the metabolic complications, be it obesity, be it dyslipidemia, be it hypertension, is running high. At the same time, the pre-diabetes, as you rightly said, even a bigger problem than the diabetes, which also needs control. Now, I think before I come to Sasank again, Subhankarta, I have a free question for you. Subhankarta, I would like to ask you, is combination therapy a way out? And before that, I love to introduce a concept which all of you very well aware, that the early control matters. In fact, the Chicago School of Medicine paper, which came in diabetes care, said first year control matters. Following that, one more paper has come this year, which we have published in the micro book, which will release in the API. Shubhankata, you have also written in that book, Sasank has written. We have said even the first 6 months control, not we have said, we have reviewed the literature, first 6 month control matters. Therefore, the early, you call it aggressive, you call it intensive. I have called it intensive. Control is paramount. Now, for that, Subhankarta, is combination a way out?
Yeah, so thank you once again for having me on this panel. Now, we are all aware of the relatively poor glucose control that we have across the globe, especially in our country. And we do know that there is something, there's something called efficacy of a drug, and there is another thing which is effectiveness. And there is a gap between the two. And this gap, to a large extent, is related to compliance. And here, I think combination treatment could be useful, especially if you have your A1Cs way off the target. None of the oral agents, and usually we do start with oral agents. Sometimes, of course, we take recourse to insulin at the very beginning. None of the oral agents, apart from metformin, possibly sulfonylurea, can achieve an A1C lowering on its own by more than 1% point, mostly between 0.5 and 1%. So in order to achieve what Dr. Shashank has just said, that A1Cs are around 8.5%, we need to bring them down to at least 7, if not even lower. Earlier on, maybe it's better to get it down even lower than 7% in most individuals without other complications. We have no other option but to use combination drugs. This could be two drugs taken separately, or it could be fixed dose combination. So I think there is a great need across the country, across the globe, and more so in our country.
Yeah, I think Subhankarta, I'll combine one more question here. We know the multiple defects of diabetes. You have written about it, Sasank written about it, from ominous octet to dirty dozen or villain 11, whatever you call it. The defects are at least 8 to 11 to 12. A single drug versus combination therapy. How do they address this multiple defects in type 2 diabetes?
Yes, I would still like to believe what maybe you and I taught and what taught in our medical MBBS days. The basic issues are still related to insulin resistance and beta cell dysfunction. Those are the most important, would explain, I think, 85% of the pathogenetic issues in type 2 diabetes. So we need to at least address two different aspects, insulin resistance and beta cell dysfunction, if at all possible. But of course, now we understand there are other issues, including very important role of the kidneys and also of the intestine, of the liver, of the brain, and all that. So yes, definitely, it'll make sense when we talk of combination of drugs. Using two sulfonylureas together clearly doesn't make much sense. Using two DPP4 inhibitors doesn't make sense. We need to use drugs that have complementary mechanisms of action and which will address different pathophysiological effects of type 2 diabetes.
Thank you, Subankar. Very great answer. Dr. Jiban Joseph, I will ask you a very simple question. There are people, there are countries, there are nations which advocate no FDC but free combination of individual drugs. The countries like UK, like say country next door, the Sri Lanka, they do not have FDC. I like to have a very small comment from you regarding the FDGs, say DAPA and MET together, or combining MET and then giving DAPA as a separate tablet.
Yeah. So thank you very much for having me on this very august panel. I think I would, kind of begin by saying that even in countries which have got very high access to healthcare, only 39 to 40% of patients actually have good adherence. And it's very clear from lots of research that we already have that almost every 10% increase in adherence leads to a 0.1% drop in HbA1c. So there's no question that treatment adherence actually matters. And that's where FDCs, probably in the Indian scenario, are a boon rather than a bane, because we do struggle with compliance and adherence, patients being lost to follow up, etc., etc. So it's certainly helpful to clinicians in the Indian setup to have fixed drug FDCs, especially if they are rational and synergistic, as Shubhankar sir said, and addresses almost 6 of the 8 the pathophysiological basis of the octet. And we also know that this combination also lowers glycemic variability and achieves HbA1cs faster. So I think considering all of that, I think there is a role for this, and a role very strongly in the Indian setting.
Good. I think it's a great answer. Now we have discussed all the aspects. We'll now ask Sasank a very deep question. Sasank, can you give us that how do we address these multiple defects in the appropriate FDC? Government of India has cut down 3. 2 is probably the most optimal combination. We are accustomed to it for a long time. What's your comment on the addressing the multiple defects by the fixed drug combination? And do you think that the answer, as all have explained so far, is the FDCs? What's your comment on that, Sasank?
So let us look at history.
Yes.
Historically, type 2 diabetes had 2 defects.
Yeah, that's Subhankar that said.
Insulin resistance and insulin deficiency. So historically, we had a sulfonylurea with a metformin. That is how the therapy started. Okay, then the birth of alpha glucosides occurred, which were basically a prandial regulator with carbohydrate blocking. That is the third therapy option which came in. But Professor DiFranzo, 25 years back, in his elegant Banting lecture, told us that it is an octet. So fundamentally, when you are addressing the octet, the beta cells make insulin, which work on different metabolic organs. So the first defect is that we have to stimulate and synthesize insulin appropriately without causing hypoglycemia. And that is addressed best by the gliptins. Gliptins switch on the beta cells and secrete insulin only when the glucose is high, but do not switch on the beta cells when the glucose is normal. So it does not cause hypoglycemia. The second thing is, inside the pancreas or the islets of Langerhans, there is alpha cells. So what happens is that they are switching on the beta cells, but they are switching off, the gliptins are also switching off the alpha cells, which are actually secreting glucagon and which is impacting the hepatic glucose output. Because fundamentally the role of glucagon is to cause hepatic glucose diarrhea. So the second defect is the alpha cells. So what is a gliptin doing? It is switching on the beta cell. it is switching off the alpha cell. Thereby, physiologically, it is increasing insulin when glucose is high, and it is not increasing insulin when glucose is normal. So no hypoglycemia. Number two, it is switching off the alpha cell. So glucagon is not secreted, the second effect. The third is the indirect effect of this is that the liver, which is where metformin works, it is basically preventing the hepatic glucose diarrhea. See, 24/7, the largest metabolic organ of our body is the liver. Even when we are sleeping, it is the liver which is giving us and converting from glycogen to glucose. So whatever is the fasting which is reflected next day morning is an impact of the hepatic glucose output. So the third defect is addressed by metformin and indirectly by gliptin is the hepatic glucose output or the liver effect. So this is the third defect. The fourth organ is the muscle. Muscle has glucose GLUT4 receptors. The fifth organ is the fat. The sixth is the intestine, which makes incretins. The seventh is basically the kidney, which has the SGLT2 receptors. And the eighth is the brain. Now, when we are looking at it from a pathophysiological standpoint, the gliptins, the metformin, and the SGLT2 inhibitors have occupied this space and addressed 7 out of the 8 defects, Professor Das, fundamentally, except the brain. And in the brain, we had a quick release bromocriptine, but that really never took off. Okay, except that the all other 7 defects are pathophysiologically addressed by the 3 major evidence-based drugs. Metformin, which is the gold standard, more than 90, 100 years old now. If you see the first paper of metformin is 1922, we are in 2023. It is 101 years old, but commercially got available only after the World War because it was a French compound, so English literature is poor on it. Okay, that is number one. Number two is a drug called gliptins, which don't cause hypoglycemia, don't cause weight gain, and are a no-brainer. By and large, compete with placebo for adverse events. And the third, which go one step ahead of a gliptin and metformin, are the SGLT2 inhibitors. Fundamentally, the advantage of SGLT2 inhibitors is that they are able to not only lower glucose without hypoglycemia, but have some degree of weight loss, but have compelling impact on cardiovascular outcomes, compelling impacts on renal outcomes. So both nephrologists and cardiologists are competing, saying that they are their drugs. So fundamentally, when you are looking at these 3 classes of agents have occupied the predominant space today in the oral space of the 7 out of 8 defects which Professor Ralph DiFranzo described.
I think, Subhangata, I have a very focused question that audience also wants to know. You know, various guidelines today are advocating the use of SGLT2 inhibitor either at the onset or just after the metformin, number a second term. And, this has been recommended different guidelines. Recently, one more paper appeared, also said about the same thing, that SGLT2 can be used in the beginning, or if not beginning, at the second. Now, can you give us some clear sight? Because one of the discussion today is the combination of metformin plus SGLT2.
Right. I must say that we have learned over the years that while glucose control is important, as Dr. Shashank has very rightly pointed out, and you've also mentioned, not only do we need intensive, good glucose control, we also need it early enough. But beyond that, we now understand that the treatment, the management of type 2 diabetes is not just about glucose control. It's eventually to prevent those complications. And there could be agents which may not be very effective in lowering the glucose levels, but can protect the organs. And SGLT2 inhibitors fall precisely in that category of drugs. So they are used and advocated across guidelines whether we talk of the ADA, we talk of the AACE, or our very own RSSDI guidelines, all of them would suggest that if the person with type 2 diabetes has either established atherosclerotic cardiovascular disease or has multiple risk factors for the same, or have chronic kidney disease, and we understand today that chronic kidney disease could mean either one or both of albuminuria and raised creatinine or reduced EGFR, then SGLT2 inhibitors would be a preferred class of drugs. GLP-1 receptor analogs are also indicated. I must say, in our country, SGLT2 inhibitors are much more convenient because we have the luxury of having many of these drugs now off patent and at a much lower price than elsewhere in the world. So many more patients can afford quality SGLT2 inhibitors at a lower cost. So yes, because of organ protection, proven evidence of organ protection, especially the heart and the kidney, these are now being recommended across different guidelines and even irrespective of glucose control. In the past, it used to be use first this, and then if the A1C is not controlled, then you go on to another agent. Now you can use them if you have those concerns about organ protection, even if the A1C is normal.
Yeah. How do you think that DAPA plus metformin has some advantage over DAPA, metformin plus SU as the initial therapy in type 2 diabetes?
Yeah, so I think in the context of all that has already been elucidated, I think it's extremely clear that the combination of metformin with dapagliflozin does have significant advantages because it crosses the glucocentric model and goes towards addressing some of the hard clinical endpoints that we require, as opposed to just focusing on the glycemic control itself. So if you use a combination of dapagliflozin with metformin, in addition to the pathophysiological basis powering it, you also have benefits in terms of the heart failure risks. Patients at high risk of ASCVD benefited. Patients have increased and better renal outcomes. There's also emerging evidence of a beneficial effect on non-alcoholic fatty liver disease. You have reduced risk of hypoglycemia. You have increased weight loss. And so you have everything that you require in terms of what you would want in terms of hard clinical endpoints and multiple benefits for a very cost-effective price. And certainly, if you look at it from that angle, there must be very strong contraindications for not using this combination, and we should be actually looking for reasons to use the combination rather than the traditional combinations.
Right, but Jivan, there's a very interesting question in the chat box. Dr. Sheikh Teruddin is the person who has asked this very intelligent question. Very simple. Blood glucose levels do not come down as rapidly or as much I'm adding with glimepiride. So with in contradistinction to SGLT2. SGLT2 0.6, 0.8, maximum 1. And the glimepiride is more powerful. So he wants to say that in case of where it is not indicated, like nephropathy, where the hypoglycemia can occur with glimepiride, why don't you think that we should go for sulfonylurea than for the SGLT2 as the initial combination?
Yeah, so again, I think it's a good question, and we do want to be able to demonstrate efficacy very quickly. But if you look at trials which have compared glimepiride to, say, linagliptin and glimepiride to SGLT2s, we see that over the longer period of time, there is not much to pick and choose between these. If the SGLT2s are going to be effective from the glycemic point of view, for which you need an EGFR of greater than 45. There might be reasons why you want to quickly get optimized things And in which case you could even consider things like insulin as well. But otherwise, if you look at the longer term scenario and the fact that with diabetes we are running a marathon rather than a sprint, I think this combination still makes sense and makes sense to probably use it early.
Yeah, maybe even also when we combine SGLT2, there are some studies which have shown even 1 and little above 1 H1C reduction. Even the individual studies showed 0.6 to 0.8, and also the huge benefit. And as Subankar also hinted at, today diabetes care also has become obesity centric. Am I correct? We had a pure 3-day discussion on the. I think you were there, Sumagarda. You came for that meeting by Mathur, Sandeep Mathur. You remember on the
I was
obesity?
there, yeah.
Yeah. So obesity as the central aspect of diabetes management, and there's no comparison of DAPA in the weight reduction compared to sulfonylurea.
So, Dr.
And
Das, can I make a comment here?
yeah, I'm coming to you. Next question
No,
entirely.
no, no. I'm just looking at what Jeevan was saying. I want to
Yeah,
dilate that a little bit.
please.
See,
Shashank,
unfortunately,
I'll just add one question to
no,
it.
no, no,
Shashank,
no. You can ask
I'll,
me the question later. This is related to this point of
okay,
glimepiride.
please.
See, we have got wedded with a concept that we want a very rapid glucose lowering of fasting and prandial without looking at the A1C. Because traditionally, when we were in medical schools, we used to only look at fasting and postprandial glucose. And therefore, we wanted quick results overnight. But the real glucose control is in the A1C control. We want both.
Yeah,
And
absolutely.
therefore, it is important to understand and contextualize it from that standpoint. Now you can ask the question.
Yeah, the question is exactly that. Now, there are some issues that some data has suggested that DAPA plus MET having distinct superiority over SU plus MET as the initial therapy. Sasank, your take on that?
So I think this is two things. See, SU-MET, what are the challenges with SU-MET? Metformin will always remain, but SU has some degree of hypoglycemia which DAPA doesn't have. SU has some degree of weight gain which DAPA doesn't have. And the main thing why SUs are waning out, though they may be very useful in the first decade of a diabetic's life, is they don't have durability. See, there is a durability and coefficient of failure. So in the good old days, if you look at Goodman-Gilman pharmacology, there used to be a coefficient of failure for a chloropropamide, for a glibenclamide, which we don't use anymore, tolbutamide, for a glimepiride, for a gliclazide, for a glipizide, and for a metformin and a fenformin. Now, if you look at it from that standpoint, the SUs are maybe very good for rapid glucose control, but over period of 5 year, 10 year, 15 year, they do not have sustainability or durability. And they do not have cardiovascular positive or renal positive data. Their data at best is neutral. Okay. So therefore, when you compare them head to head, a DAPA MET versus say a SU MET, clearly the superiority is for a DAPA MET for two reasons. Number one, no hypoglycemia. Number two, no weight gain, maybe some weight loss. Number three, positive cardio-renal outcomes. So therefore, and number four, long-term sustainability or durability.
I think that's what.
So when you look at it from a holistic standpoint,
Yeah, I think.
clearly the pharmaceutical and clinical advantages are reasonably compelling and overwhelming to make them as a agent of choice over a traditional SU metformin. And therefore, worldwide, if you see North of America, if you see Europe and rest of the world, this combination is on the wane.
Thank you. I think Sasank, very significant answer. It also answers the question Dr. R. Sasikiran has posted. Sasank, the Sasikiran exactly has asked the same question that, we know that the drug of choice, if the fasting sugar is between, say, may modify it between 150 and 180, it is glimepiride because it's very effective and brings it down. He says that what is the other drug that can use? I mean, he's referring to probably a GLT2. If the fasting sugar is, if the blood sugar levels may not be fasting alone, is between 150 and 180, are the drugs that you are suggesting now are as effective?
So first thing is glucose is only one metric in
Yeah.
my overall diabetes management.
Correct.
And I'm appreciating his question because you have to look at the age, the duration of diabetes, the associated comorbidities, the renal, the liver, the cardiac comorbidities or complications the patient has, the amount of vascular complications there, the past history of vascular episodes. Is the person having an associated life-threatening disease or not? So I think the glucose control is not centric only with a tunnel vision of glucocentricity, which Jivan very rightly said that we are moving beyond a glucocentric tunnel of a glucose control to a more holistic, comprehensive care of diabetes in a continuum of care. And therefore, yes, SGLT2 inhibitors are there, but sometimes you need to tweak for individualized or precision approach, because there will be situations where, for example, somebody has a pyelonephritis, the same individual, then my choice may not be the SGLT2 inhibitor. But in the absence of a pyelonephritis,
I
it
got you.
doesn't cause UTI. So you have to be very clear in individualization of therapy. And I think SGLT2 with metformin are becoming agents of choice, and gliptins and metformin are becoming agents of choice, both in primary care, secondary care, and tertiary care, both in diabetes practitioners and people who are in allied health, like cardiology and nephrology. So I think it is pretty compelling and straightforward in this area. And therefore, even for 150, 180, I think it is reasonable to use an SGLT2 inhibitor with a metformin combination.
I think we had a good discussion about it. We had discussed all the aspects. I leave it to the audience to assimilate it. It's about the multicentric approach, about the weight-centric approach. Combining the two drugs, the drop in the blood glucose is much higher, and negating the effect of the fear of hypo or even weight gain. So all this stands tall when we use this combination of DAPA plus MET, and we must move with time. I think that's one of the what I like to say, Subhankarda, Jiban, Sasank. We must move with time. And now the drug that has come, which has given a lot of benefits. DAPA plus sitagliptin has stood out tall today, and we can discuss about the which are the gliptins which are undergone clinical trial, which has cardiovascular CBOT trial data, and and what's the comment on the DAPA plus SITA combination? I'll go to Jiban, Subhankarta, and Sasank. Very brief comment, because we have got another 20 plus 5, 25, 30, 25 minutes more.
Yeah, so I think brief comments about the DAPA plus SITA combination is that they're both top of the line drugs, both in terms of the breadth of experience that we have and also the clinical trial data and real world evidence data. Sitagliptin obviously has the TCOS trial to back it up, and dapagliflozin has the DAPA CKD trial, the DAPA HF trials, and also the trial showing reduction in the ASCVD risks. So there's no doubt that in terms of addressing beyond glycemic control, this combination is tried, tested, and proven. As previously outlined, it does give you good glycemic control because of it being a combination, and you can achieve HbA1cs faster with no risk of hypoglycemia and less weight gain. So I think there's no reason not to use it. And my own take on this is that there should be contraindications not to use the combination along with the gold standard of metformin, if that is also indicated.
Yeah, I remember Sasank and Subhankarda, and of course Jivan. I remember Professor R.D. Lele. R.D. Lele, when before the other gliptins were introduced, cheaper gliptins came to market. I'm referring to gliptin. He spoke to me while I was in the ministry that the Africans prepare and manufactured the anti-HIV drugs without a license, and the whole world accepted it. He said that gliptins are so good, and gliptins are also good for India because, as we just now discussed, it has a better effect in Indians. He said, if the government is not willing to bring down the price, not going to do something about the patent, why not we start manufacturing gliptins? I'm just telling it by the by to emphasize that gliptins are another wonderful drug in the armamentarium. And it is rightly said by Sasank, Subhankarda, and also by Jiban that it is for Indians, is a better drug. And gliptinize India was one of the call given some time back, gliptinize India. So what is the take on the, we have heard Jiban, we'll hear it from the Subhankarda for the SGLT2 and gliptin combination. I will ask Shashank the most vital question: how to position differentially the SGLT2 plus MET and SGLT2 plus gliptin. Subhankar, the next Shashank.
Right. So about this combination, beyond what has already been captured by G1, I would suggest I'll sort of extend the concept that you've been just propounding, the Make in India concept. So we may not be having a sitagliptin dapagliflozin combination elsewhere in the West, but so what? These are the ones which have come off patent earlier in our country, and they are excellent partners to be combined to give safe and effective combination. So we should embrace that and try and make the best use of it in the interest of our patients. So that's my short answer.
Yeah, I think absolutely correct. This is the only gliptin which has undergone the CBOT trial, and it has been shown to be at least neutral compared to saxagliptin others, and therefore it can be there. We also know the cutoff points for the kidney failure and all that, so it can be there. Now I will ask Shashank to tell us that that DAPA and SITA are the most evidence-based SGLT2 gliptin combination. And how will you station it? How will you position it? How will you give it to the to all of us who are practicing diabetes in our armamentarium? Shashank?
So, Professor Das, beyond with what Professor Shubhankar Chaudhary ji and Jivan ji said, there is one important pharmaceutical point. When you combine a gliptin with a SGLT2 inhibitor, okay, the only rate limiting step of easy use of SGLT2 inhibitors is genital mycotic infections.
Absolutely.
And the DPP4 enzyme in the fungus is inhibited by DPP4. So there is data which was picked up in the phase 3 registration trial of EMPA and linagliptin by Professor DiFranzo and multiple other authors when it went through registration in the United States for the US FDA. And from that, it was correlated that when you combine a gliptin and SGL2 de novo in the beginning, then the incidence of genital mycotic infection is less. Therefore, you have the best evidence-based gliptin, sitagliptin, best evidence-based gliptin, dapagliflozin, and when you are combining either, the likelihood of genital mycotic infections, at least based on retrospective data, is going to be lesser, which is a major rate limiting. So there is some biological basis to it. And of course, we need to be pharmacovigilant. But I think this is an important and interesting observation point all of us need to highlight beyond what Professor Chaudhary and Professor Joseph told us. So this is one. Second
Good.
is
I
that
at this point.
that you see, Sita Dapa are both off patent. Both of them are now in the generic space. So they are available, affordable, accessible, and they have, you know, neutral to positive data from an outcome standpoint of cardiorenal. They have reasonable data that there is no hypoglycemia. At best, they are weight neutral or weight can cause weight loss. So when you have so many advantages, I think it is important to make a armamentarium change in way we think. But having said all this, Professor Das, I think we need to still individualize. One size doesn't fit all in today's type 2 diabetes care. We have clusters, we have, various clusters of type 2 diabetes, and one size doesn't fit all. So individualization is the key. And a large proportion of the Asian Indian phenotype cluster uh, will see a fit in this combo. But as I said, one size doesn't fit all. We are four individuals. All four of us have different BMIs. All four of us have a different uh, culture at home. All four of us eat different foods, have a different lifestyle. And if all four of us have type 2 diabetes, the approach is not going to be the same. So I think the key to all the people who are listening to this is that beyond using these combinations which are affordable and accessible, individualization is the key. So rather than saying A is good and B is bad, I think there is a place for each of these combos for that particular phenotype. And therefore, it's important that when we see our patient or a person living with diabetes in our clinic or office or in the hospital, I think it's important to ensure that we are able to put them into a cluster and then sort of mix and match treatment opportunities and options for that particular cluster.
Okay, I think good. I think, Sasank, I'll ask you the issue regarding DAPA kidney, the DAPA kidney trial, DAPA kidney study, why it was stopped early, and what are the take-home messages in your own language, not the percentage and all that.
Napa kidney, I'll be quick and succinct, clearly showed compelling benefits. So the Data Safety Monitoring Board felt that the placebo group cannot be left untreated. It's unethical to leave them untreated. And therefore, the trial was prematurely terminated because it's a clear nephroprotective agent. So our nephrologists now have an option both in the diabetes space and in the non-diabetes space, an agent between beyond ACE and ARB, which is nephroprotective both in the space of microalbuminuria and eGFR slope reduction. So clearly we have compelling data that we have an inbuilt molecule, which is a glucose molecule, which is a cardiovascular molecule and a renal molecule. And DAPA CKD trial, which was prematurely terminated, or the DAPA renal trial, clearly showed that the renal benefit is compelling. The need for renal replacement therapy, the need for people going on dialysis. So if you want to hit hard, hit early and save and salvage the kidney, the APA kidney trial clearly separates out the boys from the men or the girls from the women. So I think that's the differentiator.
Fantastic.
In a very
Fantastic.
simplistic way, compelling data, renal molecule, cardiac molecule, diabetes molecule, endocrine molecule, pleiotropy, just like what statins did to cardiology. With pleiotropy, with stabilization of the plaque, I feel SGLT2 inhibitors and maybe with proven cardiovascular benefit, which DAPA has, is doing into the field of endocrinology, diabetology, cardiology, and nephrology.
I think it is a great revelation that in today's world, DAPA is the glyphogen which is easily available to all of us, affordable to all of us, and it has great benefit on the heart failure data. It has a great benefit on both types of heart failure, reduce the precipitation fraction. It has a data to show that it is kidney friendly. So I think the question of combining it with either sita or metformin is absolutely above board and a very welcome combination.